Our next section is really interesting. We've worked our way down from the atria and the AV junction to the ventricle, and ventricular arrhythmias can be pretty severe because they directly affect the major pumping function of the heart. The hallmark of most ventricular arrhythmias is a wide QRS, and the reason for this is that it takes more time for electrical conduction to go from muscle to adjacent muscle, rather than the fast, efficient ventricular conduction system. There are, of course, some notable exceptions like fascicular or bundle branch reentry that are highly dependent on the conduction system, but for the most part, ventricular arrhythmias have a wide QRS. Here's an outline of this section. We'll start with some examples of long QT that causes ventricular arrhythmias by increasing the vulnerability of repolarization. Then we'll talk about individual electrical events in the ventricle, premature ventricular contractions. Next, we'll review sustained repetitive ventricular beats, ventricular tachycardia. And then we'll go over the life-threatening rhythms, torsade de pointes, ventricular fibrillation, and asystole. So our first ECG shows long QT syndrome. If you look in lead 2, you'll see that the time from the Q wave to the end of the T wave is longer than expected. In fact, this is longer than about 450 milliseconds, or 2.5 big boxes, which is more or less the cutoff for most long QT syndromes. Another thing that you can see is that the QT interval is greater than half of the R to R interval. This is another tip-off that the QT interval is inappropriately long. QT duration can be affected by heart rate. Therefore, we often calculate a corrected QT interval that takes heart rate into account. The formula for this is the corrected QT interval is the QT value divided by the square root of the R to R interval. There's no need to worry about this in real life because this is usually calculated at the top of the ECG by the computer, although sometimes you have to do it by hand if you don't believe what the computer is calculating. And here's another example of long QT interval that's seen on the EKG, but this time it's caused by a drug called sotalol. Look in lead 2 below. You can see that the QT interval is about half of the R to R interval. There are a lot of drugs that can cause QT prolongation. Antiarrhythmic drugs like sotalol, antihistamines, antibiotics like quinolone or erythromycin, antidepressants like amitriptyline, and methadone, for example. On tests, you may be asked about patients who have a predisposition to long QT, and then you'll be asked to not add another drug that might prolong the QT interval and thus cause serious arrhythmias like torsade de pointes. Okay, so here's our first arrhythmia, premature ventricular contractions. In the yellow box, I've highlighted a premature ventricular contraction. Notice how this beat came a little earlier than the expected next beat. Also notice how the QRS wave comes without a preceding P wave that is coupled with the QRS. And notice that the QRS is wide. This demonstrates that the rhythm originated from the ventricle and not from the atrium. You can see that the morphology or shape of the QRS is different from the preceding sinus beat. And this also shows that the ventricle was activated from a region separate from the normal ventricular conduction system. So a PVC is like an extra electrical firework that went off in the ventricle and took control of at least one ventricular beat. Sometimes PVCs can become more and more frequent. Here's an example of 3 PVCs in a patient with underlying bundle branch block. PVCs are very common in patients with structural heart disease or ischemia. A PVC burden in the 20% plus range is considered very high and is usually a reason for drug or catheter intervention. I like this ECG because it shows the difference between a PVC and a fusion beat. In the yellow box, you can see an example of a PVC, which is an early wide QRS with no coupled preceding P wave. In the green box is an example of a fusion beat. A fusion beat is interesting because it happens when a PVC from below in the ventricle collides with a normally conducted beat that's coming down from the atrium. The result is a beat that resembles both a normal beat and a PVC. It is essentially a fusion between the two. Next on our list is a really serious arrhythmia that is a common cause of death in patients with heart disease, ventricular tachycardia. Ventricular tachycardia is a repetitive run of rapid ventricular beats that takes over the cardiac rhythm. Many times in post-MI patients, you have a repetitive run of VT that has the same shape QRS. This is from a phenomenon called reentry. The idea is that an electrical circuit can spin around and around a boundary like a scar, causing repetitive waveforms on the ECG like ventricular tachycardia. Here's another example of VT. You can see a wide, ugly QRS wave and no easily discernible P waves. Sometimes you can see AV dissociation. Notice in lead V1 how long it takes from the bottom of the wave to get up to the top of the wave. This long upslope usually takes longer than about 0.16 seconds and is a sign of VT. Here's a sign that you might be dealing with a VT. If you have a wide QRS complex tachycardia, and then this is interrupted by a perfectly conducted beat that resembles sinus rhythm, this is a capture beat and represents strong evidence, but not proof, that the underlying rhythm is VT. Here you can see that in the midst of a run of VT, we have a set of two capture beats that sneak in early and perfectly capture the ventricle. Then you can see that the VT resumes. This is strong evidence of VT. Just as we saw fusion beats before with singular PVCs, we can also see fusion beats during runs of VT. Remember that fusion beats are a fusion between sinus beats that are conducted from the atria and also VT that is happening in the ventricle. In this ECG, you can see two beats that are more narrow than VT, but are probably not directly sinus beats. These are fusion beats, and again, these are strong evidence, but not proof, that the underlying sustained rhythm is VT. Here's a classic arrhythmia that you will see on the wards and on the wards. This is a potentially fatal arrhythmia called torsades de pointe, or point twisting, which is a common polymorphic ventricular tachycardia. Notice how the rhythm is changing and tends to have big and then small VT waves. If you hallucinate a little bit, it almost looks like you're having party streamers. Torsades is often the result of long QT intervals we saw earlier, or hypokalemia or hypomagnesemia. Your immediate treatment for torsades is a shock, or CPR. You can also give IV magnesium, as this helps to stabilize the cardiac membrane and correct hypomagnesemia. If left untreated, torsades can quickly degenerate into an extremely disorganized arrhythmia called ventricular fibrillation. In this arrhythmia, there's essentially no coordinated contraction of the ventricles. It is as if the ventricle is moving like a bag of worms. The ventricles have no coordinated pumping function with VF, and thus this is a fatal arrhythmia if not immediately treated with a shock and CPR. Here's the same patient who progressed to fine ventricular fibrillation. Notice how the low voltage rapid waveforms essentially represent no coordinated cardiac activity. And then here's an ECG strip of the patient being shocked. You can see that on the left there's ventricular fibrillation, and then you see an arrow and a black line representing the electrical shock. And then after this you see that the patient returns to a sinus rhythm on the right. Finally, you can see here an example of VT that is changed to asystole. And so asystole is essentially uncoordinated movement of the cardiac rhythm that is essentially fine or zero electrical activity.